This conference will now be recorded.
Welcome, everybody. We are going to be talking about Chapter 13, which is patient assessment. So, a very important chapter. This is one of the components that you should probably re-listen to this lecture, carry around your NREMT patient assessment sheets. And then this is one thing that you can start practicing too, because there's a bunch of different scenarios online that you can utilize. So our objectives for this chapter, we're going to be talking about scene size up, which is going to be a review from the previous chapter, our primary assessment, secondary assessment, both trauma and medical related, and then reassessing what we've done. So this is our algorithm in our assessment chart that we're going to be following. So previous chapter, we talked about scene size up, which is going to be taking our BSI precautions, identifying any potential hazards and ensuring that scene is safe, recognizing whether it is trauma related or medical related, utilizing our mechanism of injury or nature of illness, followed by identifying the number of patients or additional resources. And one thing that we didn't touch on too much in that previous chapter is this is when we should also be identifying whether this patient needs C-spine stabilization. So we've identified all of our scene size up components, and this is where we are going to approach our patient and utilize our primary assessment. So again, we'll review our scene size up. So based on the picture that we see, looks like an individual cut himself with a saw. So taking our BSI precautions, so gloves, any type of eyewear, possible gown, depending on how much blood loss there is. Scene safety, so possible electrical wires, making sure that that saw is off and out of the way. Mechanism of injury or nature of illness. So this is identified as a mechanism of injury, trauma in relation. We have one patient. As far as additional resources, we might be considering advanced life support depending on how bad the bleed is, and also be thinking of pain management as well. And then thinking about C-spine precautions. So if this was an isolated injury where he simply caught himself with the saw, no fall, no C-spine precautions, then we probably wouldn't have to worry about stabilizing that C-spine at this point. So now we're moving on to our primary assessment. So the components that are going to form our primary assessment are forming a general impression. We are then going to go on to assess mental status, going to our ABCs, our airway, breathing, and circulation, establishing that patient priority, whether this was a patient who's a load and go or to continue to do your secondary assessment and treat on scene. So I'll dive deeper into our general impression, the components that make up our general impression, which are going to be things that we can see right when we approach that patient. So we're going to estimate the patient's age, sex, determine if patient's a trauma or medical patient. Again, this is re-emphasizing our scene size up, obtain the patient's chief complaint, and identify and manage any immediate life threats. So when we approach this patient, after we have done our scene size up, we'll dive into our general impression. So I see a 20-something-year-old male patient, victim of a traumatic injury from a motorcycle accident. Any immediate life threats, it looks like he's got a pretty good sized bleed coming from the patient's head. And then also I'm looking at scene safety considerations. So scene safety isn't just within that scene size up, but that's going to be reestablished after everything that you basically do. Then for this patient, again, utilizing our general impressions. So we have a 56-year-old male patient, alert and oriented, looks to be complaining of chest pain. That's his chief complaint. Nature of illness is going to be cardiovascular in nature. Number of patients, again, is 1. And we are going to continue on to our primary assessment 2 with our ABCs with this. General impression, 24-year-old female patient. Could be a mechanism of injury or a nature of illness, but this is going to be a drowning victim. 24-year-old female patient. Nature of illness is going to be GI in nature, nausea, vomiting, and then mass casualty incident. So difficult to get a general impression on your patients when you have an MCI. So biggest thing with MCIs is giving a rough estimation as far as how many patients there are to voice that to the hospital and any dispatch information. So when we are identifying any immediate life threats during that general impression, these are the life threats that we're looking at. Is any compromised airway, open wounds to the chest, paradoxical movement, which I'll describe in the next few slides, any type of major bleeding that we can see, and unresponsive with no breathing. So all of these immediate life threats, when you do identify them in your general impression, they need to be taken care of immediately. So if I get to that compromised airway when I'm forming my general impression, I immediately fix that airway before I move on. And same with all of these other immediate life threats. So when we have a compromised airway, these rescuers are identifying that this patient rescuer is actually maintaining C-spine stabilization and maintaining a good patent airway at the same time. This is an open sucking chest wound from a gunshot. So what we're going to utilize is a chest seal in order to create an occlusive dressing, so we're not allowing air in to that chest cavity, which could compromise and lead into a tension pneumothorax. This is an example of paradoxical movement or a flail chest segment. This is multiple broken ribs in multiple locations. And so we can see a separation of that rib cage. So when we inspire and our chest cavity expands, that flail chest segment actually depletes and goes into the lung cavity, and vice versa when we're expiring. So it really causes a lot of tissue damage and is difficult for that patient to actually inhale and exhale at that point. So as far as treatments go, we'll identify those once we get into our trauma-related stuff. But a big bulky dressing or simply a hand over that flail chest segment to try and go with inspiration and expiration when that patient is breathing. And then major bleeding, again, identifying that, stopping the bleed with direct pressure, or if we have a substantial bleed, maybe going straight to our tourniquet application in order to stop that bleed. And then we have a patient here, unresponsive, not breathing. So if the patient does have a pulse, we'll immediately start rescue breathing for that patient. If the patient does not have a pulse, that's where we would start our CPR algorithm. So within that scene size up, and then also that general impression, we should be thinking of in initializing our inline stabilization. So if we've identified that patient has suffered from a traumatic injury or a possible traumatic injury in which the spinal column was affected, we're going to immediately establish inline stabilization utilizing one of our personnel on scene. So that person is going to take one hand on each side of that patient's head and then make sure that that patient doesn't move at all. So we're not really treating the injury, but we are preventing any further injury from occurring when we do maintain that inline stabilization. Bring that head neutral in line between the nose and the navel. That's going to maintain that good inline stabilization. So when we are doing this and we have to open up that patient's airway, remember to use the jaw thrust maneuver on this. So here we can see a good example of this rescuer maintaining that C-spine precaution, also holding that airway patent at the same time. And it looks like they have a makeshift C-collar through a shirt or sweater of some kind. So then we're going to position the patient for assessment. So depending on your patient's mental status and also chief complaint, this is what we're going to utilize as far as information goes in order to position that patient properly. So if they are unresponsive, we should position them in a supine position in order to conduct our assessment. Now, if they're alert and oriented, put them in a position of comfort. So for example, our patients who have difficulty breathing, they might want to position themselves in that tripod position because that's going to be most comfortable for them. Be mindful of any injuries, especially when you're maneuvering the patient. So if you're log rolling the patient, be mindful, if they have injuries to the left side, you don't want to be log rolling them on their left side when you're either putting them on a backboard or putting them on the manta. Patients should never be positioned or left in the position of a prone position because this could lead to asphyxiation. So never transport a patient in prone. If we show up on scene and that patient is in a prone position, immediately log roll them into a supine position so you can better assess their airway and better manage any other injuries or airway breathing circulation components. So we approach our patient, we did our general impression, we made the decision whether to apply C-spine precautions or not, and now we're going to start diving into our primary assessment. So we are utilizing the AVFU scale for check-in level of responsiveness. So if I approach my patient, they're able to track me and they can answer my questions, they are going to be alert. Now, if they're able to communicate properly and give me good answers, then they're going to be alert and oriented. And we'll talk about the Glasgow Coma scale in a couple of steps here. Now, if I approach my patient and they are only responsive to verbal stimuli, then they are going to be classified as verbal responsiveness. If I have to do a sternal rub or any type of painful stimulation in order to actually get a response of that patient, they are being considered painful responsive. And if they are completely unresponsive to any type of pain or verbal response, they would be classified as unresponsive at that point. So here's my patient, I approach him, he's tracking me, he's able to communicate with me, he would be considered alert. Here's my patient, only responsive to verbal stimuli, he would be classified as verbal. Utilizing that sternal rub, so we should be doing this with our adult patients. Now for our infants and small pediatrics, they are most prone on the bottom of their foot. That's where they're most sensitive. So we should be flicking the bottom of their foot in order to trigger that painful stimuli. And then this patient, completely unresponsive, opening up that patient's airway immediately, and then going through our ABCs. So different posturing that we can see with the patient, specifically if they have some type of central nervous system injury or a head injury, could be decorticate or decerebrate posturing. So decorticate is going to be when the patient is flexing and arching their arms toward the core of their body. Decerebrate posturing is going to be that arms, legs might be extended away from the body. So these two signs and symptoms, if we see that in our patient, are very concerning. Again, this is going to be a mark of a central nervous system injury or a head injury. So this is what those two positions look like. Usually when a patient is displaying signs of decerebrate posturing, that's a little bit worse than decorticate, because with a patient who's displaying decorticate posturing, they still have some type of instinct to try and protect themselves by utilizing that decorticate posturing. All right, so we've done our scene size up, we've done our general impression, we've checked responsiveness, and now we're going to get into our airway, breathing, oxygen therapy, and then circulation. So we're going to assess that patient's airway, determining status. So is that airway patent or closed? If that airway is closed, that patient's unresponsive, we can go ahead and open up that patient's airway, utilizing the head tilt chin lift if we don't suspect any type of C-spine injury, or utilizing the jaw thrust maneuver if there is some type of C-spine injury. Now, if we open up that patient's airway and there's a heavy amount of secretions, vomitus, blood, what have you, go ahead and utilize your suction protocols, whether it's with the portable electric suction unit or the VVAC, and then go ahead and clear that patient's airway with that suction device. Here, good example of utilizing that jaw thrust maneuver to open up that patient's airway. Once we've established that that airway is now open, we can move on to our breathing. So you could see in that previous slide that if we identify any issues with that airway being closed, we're stuck on that airway until we fix the airway, then we're going to move on to our breathing status. The only caveat behind that is if we have identified that patient's in cardiac arrest, then we immediately start our CPR algorithm. Now, when we're assessing breathing, we talked about this when we went over vital signs. We're going to look at rate and quality, assess that oxygenation level, and then we're going to start to decide what type of oxygen therapy that we need, if we need that oxygen therapy. So if a patient's respiratory rate generally is less than 6 or greater than 24 and they are unresponsive, we're going to start assisting ventilations. Now, if we've identified that they meet the curriculum of any type of oxygen therapy, such as a non-rebreather or a nasal cannula, after we assess that breathing status, we should immediately initiate our oxygen therapy. So a patient who's complaining of chest pain, a lot of times in most EMS protocols, they will ask for oxygen therapy. And so I've identified patient does have chest pain. My protocol says that I should start them at 2 liters per minute. Once I assess that breathing status, that's where I dive into providing 2 liters of oxygen via nasal cannula. Now, if a patient's displaying signs of hypoperfusion or signs of shock, that's where I would immediately initiate my non-rebreather mask with my high flow oxygen levels. So I fixed the airway, I established breathing, I provided oxygen therapy, and now I'm moving on to my circulation. So I'm checking that pulse, looking for other major bleeds that I may have missed when I did my general impression and looked for that immediate life threats. Now I'm looking for skin color, temperature, and condition. Now I can be doing this at the same time as I'm assessing airway and breathing. This can be done by simply placing my hand on that patient's wrist and identifying that radial pulse, because I can look at the same time for that skin condition and assess that airway, breathing, and circulation almost all at the same time. Looking for capillary refill. Again, this is not the best sign or tool to use for assessing our adult patients, but it's a great tool for our pediatrics and infants. So looking at this patient, they're displaying signs of cyanosis. So this is an immediate life threat. This patient, if they have not received oxygen therapy yet, they should be receiving oxygen therapy immediately. So once I get through my ABCs, this is where I'm going to identify my patient priorities. So if I have seen anything that compromises the ABCs, I'm going to classify this patient as unstable. I'm going to perform a rapid secondary assessment and get ready for immediate transport. Now, if there is nothing wrong with the ABCs, or if I've maintained that well, then I can classify them as stable. And then I'm going to continue on with my secondary assessment on scene, provide any interventions, and then I can get that patient ready to go for transport. So with my secondary assessment, I'm going to conduct a physical exam. Depending on my patient and their chief complaint, I can either do a body-wide physical exam, or if they just have a specific complaint or a specific injury, I can focus on an isolated portion of that patient's body. From there too, I'm going to either take baseline vitals or advise my partner to go ahead and start taking my baseline vitals depending on how many resources I have. I'm going to obtain my history, so utilizing that sample history. So sample again stands for signs and symptoms, followed by allergies, medications, past pertinent history, last oral intake, and then events leading up to. With that signs and symptoms component within the sample history, OPQRST, onset, provokes, quality, radiation, severity, and time. So now we're diving into our secondary assessment a little bit more in detail. So when we're using the anatomical approach for a medical patient, if they are unresponsive or have chief complaints of multiple body systems, we're going to start at the head and then we're going to work our way down. So we can divide this into either a detailed approach or a rapid approach. So for any patient who's classified as unstable, you're going to do this in a rapid motion, get that patient ready to go for transport, and then you can conduct a more detailed exam once you're in the ambulance. So when we're going through our secondary approach, using the anatomical model, we're going to assess the head, the ears, face, eyes, and mouth. From there, we're going to move down to the neck. We're looking for any type of step off in the back C-spine area, any JVD or tracheal deviation. From there, we're going to look, listen, and feel to the chest. After we get done looking, listen, and feel, we're going to go ahead and take our stethoscope and we're going to oscillate over those lung sounds. From there, move down to the abdomen, expose the patient, check all 4 quadrants of the abdomen. So looking for DCAP, BTLS, and all of these components. Check the pelvis, check for stability, check for any type of bleeding. And then from there, you're going to go through the lower extremities, check for CMS, and then you're going to go back up to the upper extremities and check for CMS. CMS stands for sensation, motor, and circulation. So for CMS, I'm going to check a distal pulse. I'm going to ask that patient to move their fingers or move their toes, and then I'm going to pinch a finger or pinch a toe and ask them if they can feel that and have them identify that specific finger or toe of what I'm pinching. If that patient's unresponsive or needs to be log rolled, that's where I'm going to assess the posterior body, because then I can place them onto my lifting or moving equipment. Now that is my body-wide system. So again, if that patient's unresponsive or not a good historian or multiple body system is affected, that's where I'm going to utilize that. Now, if the patient has one chief complaint or an isolated injury or system, I can dive into the specific body system that's affected. So if the patient has complaints of difficulty breathing, I'm going to go ahead and assess that respiratory system, looking for chest shape, symmetry, any accessory muscle use. And again, I'm going to dive into my auscultation, pre and post any type of intervention. Patient complaining of chest pain or cardiac in nature, I'll then dive deeper into the cardiovascular system. So checking peripheral and central pulses, the rate, rhythm, strength, and location, blood pressure.
This conference will now be recorded.
Then a patient complaining of any type of issue in regards to the neurological system. So our stroke patients, loss of sensation, even our traumatic patients too, who are complaining of deficits, right, left, both. For that neurological assessment, we should dive deeper into the mental status, posture and motor activity, leading back into that decorticate and decerebrate posturing, any type of facial expression, speech, language, mood, thought process, memory. Memory is key too when we're dealing with patients who are in the geriatric age range, as far as what is their normal baseline behavior for that. And then musculoskeletal system too. Patients complaining of isolated injuries, we can dive deeper into examining on a physical, and then also viewing that injury site as well and doing a good proper assessment. So when we're diving into our secondary assessment, again, baseline vitals, we should be taking these. And then what we're looking for with vitals too is any trends within those vitals. So textbook is going to talk about taking vitals every 15 minutes for our stable patients and every 5 minutes for our unstable patients. If you got multiple resources on hand, you should be taking them as soon as you can, especially when you have interventions that are going on. You want to see if that patient is responding to those interventions, whether positively or negatively. Again, obtaining that history, talked about sample history when we were going over vital signs and history taking. So utilizing that sample, utilizing that OPQRST. Now, a little bit more specific when we're dealing with our trauma patients, when we're performing a rapid secondary assessment, this is going to be followed by that prompt transport or on-scene emergency care. So when you would delay as far as transport is if you have to perform interventions in order to actually save that patient's life. So inserting an OPA or an advanced airway, applying a tourniquet, one of those interventions that needs to be conducted immediately. With a modified secondary assessment, this is again to a specific injury site. Very similar to our medical patients where somebody's complaining of chest pain, we're diving deeper into the cardiovascular system. With a modified secondary assessment, if somebody's complaining of rolling an ankle or an isolated knee injury, we can focus more specifically on that injury site and don't have to tailor into the entire body system. So with a rapid secondary assessment, this is going to be conducted for our multi-system trauma. With multi-system trauma, every patient is going to be maintained with that C-spine injury, especially any patient with an altered mental status. So first, continue holding C-spine. We always hold C-spine until that patient is completely immobilized to the backboard, unless there is a scene safety consideration where we actually have to back out of that scene. So consider any type of advanced life support at that point. Reconsider our transport decision, whether you're going to stay on scene or if it's an immediate patient where you're going to perform that rapid trauma assessment and then get that patient loaded. Reassess mental status and then perform your rapid secondary assessment utilizing that anatomical model where you're going from the head down to the feet and then using and viewing, examining the upper extremities as well. So when we are practicing this in the lab session, make sure that you're actually getting your hands on your partners when we're utilizing our partners for this. Be cognizant of people's privacy. And when we get to the 1% or the genitalia area, just voice that you would conduct that. Again, be very mindful of people's feelings during this. When you are conducting your trauma assessments, medical assessments on the SimMan, really get your hands on these patients because how we practice is how we're going to actually operate out in the field. So when we are conducting our mental status too, when we're diving deeper into exactly what their mental status is for documentation purposes, and again, using those trends for vital signs, we're going to utilize the Glasgow Coma Scale. So it's broken up into 3 categories: eyes, verbal, and motor. And so each category has got a different scoring system in association with how they respond or if they don't respond. So based on these 3 categories, you add up the number. So if somebody's alert and oriented, they're able to follow commands, then they are going to be at a Glasgow Coma scale of 15. Now, if they're completely unresponsive, don't respond anything to verbal, eyes, or motor, then they would have a GCS score of 3. So the lowest score you can get is a 3. The highest score you can get is a 15. So in order, again, utilizing that anatomical model for rapid secondary assessment, this should be conducted within 30 seconds to a minute. Now, once we get that patient in the ambulance or we're more secure with our interventions, we're going to go back and do a more detailed secondary assessment. But with a rapid secondary assessment, getting your hands on that patient's head, looking in the eyes, mouth, nose, ears, again, very quickly. And what the purpose of this secondary assessment is when we're doing it rapidly is trying to find any immediate life threats that we didn't see when we were doing our general impression and going through our primary assessment. Now, when we do identify injuries, so let's say we're going through a rapid secondary assessment, we identify a knee injury, an ankle injury, a wrist injury, something that's not life-threatening, we're going to note that and then just move on, because I don't want to waste my time splinting an injured wrist when somebody who's got a GCS score of 4 and is not breathing properly. When we are doing our more detailed and our rapid secondary assessment, this is a good mnemonic to use as far as what we're looking for. This is referred to as DCAP BTLS. D is deformities. So what you can do is utilize the different portions of the body. So if you're assessing the right arm and it doesn't feel right, use the left arm for your reference point. C is contusions, so bumps, abrasions. P is going to be for punctures, penetrations. B is burns, tenderness, lacerations, and swelling. So on Thursday, our lab day, we're going to be diving deep into our secondary assessments or patient assessments, taking our vitals. So be prepared for that. If you have to rewatch this lecture, make sure that you're keeping up on your homework, and I will see you guys at our next lab. Thanks.